Ladies and gentlemen, thank you for your patience in holding. We now have your presenters in conference. Please be aware this conference is by express written invitation of the AHA only. Unauthorized participants and or any party that aids and abets such unauthorized participants may be subject to criminal and civil penalties under both state and federal law. Please log off the webinar and or disconnect from the phone if the AHA did not expressly invite your participation. You may submit your questions electronically at any time during today's presentation by using the chat window located to the right of the slideshow presentation. Above that, you'll see a window labeled Files where you may download a copy of today's presentation. It is now my pleasure to introduce today's first presenter, Mr. Benjamin Lutz. Please go ahead, sir.
Thank you, David. My name is Benjamin Lutz. I am the Senior Advocacy Associate with the American Society for Healthcare Engineering at the American Hospital Association. Today, my role is to be the MC of this webinar. Today's topic is alternate care sites utilizing hotels for patient space. I will now turn the time over to today's moderator, Kara Brooks. Kara, your show.
Thanks, Benjamin. My name is Kara Brooks. I am the Sustainability Program Manager for ASHE. I'd like to thank you for joining us today. ASHE has been working hard to provide resources to the field in this time of need. We have developed resources related to alternate care sites for surge patients. Today, we have experts from HKS Architects and IMEG here to provide an overview of key architecture and MEP considerations for converting a hotel into patient space. With that, I will turn this over to our panelists.
Okay, I'll kick it off. My name is Stan Shelton. I work in the health practice with HKS Architecture. If you don't know us, we're a global firm with 24 offices and about 1,400 people, and our largest practice area is actually in healthcare. Prior to joining HKS, I spent about 30 years as a healthcare executive, and for much of that time, I was responsible for the environment of care, emergency management, and planning, design, and construction of various projects. And the last 10 or 12 years, I led over $500 million in construction projects from conception through occupancy. So next slide there, Kara. So why a hotel? Why convert a hotel to an alternative care facility? HKS first got involved in this fight against COVID-19 by assisting many of our clients, perhaps some of you, with expanding your pre-existing surge plans and your emergency preparedness plans. That was triage, bed capacity, et cetera. But while working on those projects, we also got involved in supporting larger scale conversions to alternative care facilities. We did 3 concept studies, one with a hotel, one with high school, and one with large venues. And today we're going to talk about the hotel. As it turns out, when we began to study that, a hotel facility and its components very closely match a hospital with a kitchen, a laundry, individual guest rooms, large open spaces, entryway, parking, et cetera. The sites generally accommodate outdoor testing or triage, as became an issue during this COVID-19 pandemic. And we determined that we could very easily convert a hotel into a low acuity care site. Patients and or staffs can use the guest rooms, and we actually can create fairly rapidly and comprehensively step-up care with wards and ballrooms or conference rooms, et cetera. And based on our study and what we think is possible, we believe that conversion can be done in 14 days or less, and very cost effectively, I might add. Next slide. So the primary planning criteria or thing that has to be taken into consideration with any of these kinds of conversions, especially specifically with a hotel, is what's the acuity and the type of patients that we'll care for. Much was in the press about a shortage of intensive care rooms, much was in the press and with ASHE and in the AEC world about converting any kind of room possible into a negative pressure room. So understanding the acuity of the patients is first and foremost required for this conversion. We went with low acuity patients that did not require negative pressure, really based on the CDC's guidelines. Second issue is what's the number of patients? And the forecast that we were hearing across the country was staggering. With at one point in time, we were following a forecast that said 40% of the United States population was going to contract COVID-19. And with the 7 or 8% death rate associated with that, the math was staggering. And that's what led to many of these conversion studies where we began to think about 1,000 beds, 1,500 beds, et cetera. Time to complete is also an issue. We can do anything if we have enough time, and we can do anything if we have enough budget. So understanding what both of those aspects are, those constraints actually, are critical to doing the planning process for this. Next slide. I'm not going to go over every piece of this flow, but this is a conceptual flow of how we might take care of these low acuity patients in a hotel. In a hotel specifically, we're talking about a full service convention type hotel because that's got a kitchen, it's got laundry, it's got large ballrooms or conference rooms or convention rooms. So if you look at the diagram on the left, we can create triage assessment testing area either in the hotel lobby or outside the hotel. And then all of the patients really, or the activity can be relatively unidirectional flow, which is really very important in controlling the spread of the virus, especially if we end up having staff and patients staying overnight in the hotel. The other thing to note based on this flow is that kind of lost in the diagram. Oh yeah, but we also have the ability to create ancillary spaces in that hotel, whether that's a lab, a pharmacy, certainly something to stock central supply services, et cetera. We have studied this, and it depends on, of course, the hotel proper, but we can create quite a significant ward atmosphere in a ballroom or a conference room, a convention room, and our other colleagues on the call today can speak to this a little bit more in detail, but the airflows in those large spaces are particularly conducive to this kind of care. While they're not negative pressure, and while the exchange rates might not be the same as in a typical hospital setting, in those large rooms, because they're designed for a massive amount of people, they can generally create or use 100% outside air in the circulation. So that's a very, very important thing from the flow. We can keep going. It's just an example that shows you how quickly or what is required to convert a guest room on the left into a low acuity patient care room on the right. Really the biggest issue that we faced there was what to do with the carpet. We all have been in hotels and we've been in hospitals, and you don't see carpet in any hospital room, and you see carpet in every hotel room. If time and money and resources allow, we would pull the carpet out of the room before we turn that into a low acuity care room. If those things aren't available, if there's not enough time, if there's not enough money, et cetera, we did study the use of carpet protection tape, which many of you are familiar with in construction projects, and we could get that in a 4 mil thickness, use 1 or 2 layers of that on the floor, and can actually exchange it in between patients, and that does provide a barrier between the carpet and what's happening in the room. So that was one of the issues. The other thing is the HVAC system in the room, and again, our colleagues are going to talk about that a little bit more. Eventually, as we got through this process, we got 8 CDC guidelines that suggested that we didn't have to worry about negative pressure, et cetera. And so our initial study suggests that for low acuity patients, again, not those ICU patients, but we would just really leave the air systems as they are originally designed for those patient care rooms. Next slide.
Yes, thanks, Dan. This is Mike Zorich with IMEG. I'm a principal with the firm and the director of healthcare. I've been in the healthcare industry for approximately 20 years. And I kind of want to frame the discussion here a little bit about some of the infrastructure and why would a hotel fit alternate care facility. And as Dan kind of alluded to earlier, there's already some built-in infrastructure that really makes sense. You know, the single occupancy space, the dedicated toilet room, showers, and sinks that's already inherently there. And then one of them that's most important is inherent life safety measures that are already found and common in hotels. That includes the fire protection and the fire alarm. So there's a lot of this MEP infrastructure that's currently there that allows us to use this within the time and budget that Stan alluded to. One of the things I do want to make clear, there's a lot of people on this call who live in the healthcare industry. A lot of you are familiar with NFPA 99 and the category risks that are within there. And this is really important from us from an MEP standpoint. It drives a lot of the life safety and measures that we would take with our systems. But this whole case study and analysis is assuming that category 3 patient, where some of the activities are not likely to cause injury or death associated with this. So again, to Stan's point, this process and what you're going to see here next with some of the systems is that low acuity patient. So moving on to Bob.
Yeah, good afternoon. This is Bob Winter. I'm the Director of Hospitality for the firm, and I'm joining you from our Chicago location. First, I'd just like to give a high-level perspective on hotel design. I think you can characterize it as being efficient with really a strict adherence to cost of construction, which does impose limitations on how easy it is to make changes or how difficult it is to airflow quantities, specifically outside air, exhaust air, the recirc air. Outside air and exhaust air quantities in a hotel room are typically low, less than about 50 CFM. The guest room itself is designed to be about neutral or slightly positive with respect to the corridor. Also, the outside air can be supplied to the corridor in older properties, or if it is delivered to the room, it can be coupled or decoupled with respect to the unit that's in the room. Some properties have PTACs or VTACs. Those are the through-wall units. I think it's important to be careful in those applications. Some of the manufacturers claim that you can bring the outside air in directly to those units, which is a bad idea. And if that's the case, the outside air should be shut off. So generally, it's just important to understand what type of outside air supply you have to understand the system design. Looking at the guest room itself, modern hotel rooms have control systems that will disable the outside air and the exhaust air to the room when it's unoccupied. We'd want to disable those controls and make sure that we're maximizing the outside air and exhaust air delivered to the building. It's really not a large quantity, and you're not going to get air exchange rates that are appreciable. In a typical 350 square foot guest room, you're only going to get about 3/4 of an air change an hour, which is very low. Understand that the units that are in the guest room are just recirculating the air. Also, in the typical fan coil unit, the filter is relatively low MERV rating. It's about 4. So to improve the air quality, quality, a HEPA fan filter unit would need to be added to the room. And then lastly, the bathroom, as we've already addressed is really sufficient with the newer properties and those that have been recently renovated having showers instead of tubs, which is very important for patient care. I'm going to pass it off to Andrew to talk about the electrical infrastructure in the building.
Yes, thanks, Bob. My name is Andrew Pomato. I'm an electrical engineer with IMEG, primarily with a focus on commercial construction of the high-rise type here in Chicago as well as nationally. So what are some of the considerations and challenges we look at when we're reviewing the candidacy for conversion from a hotel to a guest room? And we may have gotten one slide ahead there. But, you know, one of the things that hotel staff typically looks at when they will review these rooms is the locations of convenience outlets which exist in the head wall at the bed. As we review some of the older facilities, mainly low-rise and high-rise hotels, we would often see trends which may have resulted in a shared head wall in back-to-back rooms in which the bed is actually on the shared wall. We would also find, or commonly find, non-grounded outlet types. And any combination of these two issues could just make the facility itself or the building itself impractical for this use. Whereas the newer buildings, we would often find more dedicated or isolated power that exists within these head walls. The electrical circuitry is often designed dedicated or typical to the room rather than typical to the wall. This is, presents more opportunity and is more susceptible for guest room conversion. You know, to Bob's point, the HEPA filter power supply is the main component. We're looking for some dedicated power. These could take up to 75% of an available circuit capacity depending on the unit which we're looking at. So when we're looking at plugging in some of the additional monitors, that is certainly a consideration on how we dedicate and isolate power for that unit. Another thing to consider is light fixture additions for pop-up nurse stations within the rooms, at the beds, task lighting, etc. The next point that we really need to hit on is emergency power. Typically in hotel construction, your power per floor that's on an emergency system is limited to the life safety systems of the building. In other words, there's no critical branch of power that we would find in a hotel or in a hospital. So a goal we may consider would be to bring emergency power to a central distribution point which feeds the guest floors as is today. That's typically via a busway in a high-rise construction setting or a distribution panel anyplace else. And, you know, that size of generator could get anywhere from 400 to 600 kW depending on the number of keys. So therefore, the other option may be to provide backup standby power for the entire building. And that size unit could get anywhere from 1 to 2 megawatts depending on the load factor of the building when we're considering hospital occupancy in lieu of hotel occupancy. And then determining the location would ultimately result in the feasibility decision for that unit depending on the physical size. A 3 to 4 story greenfield hotel would likely have a parking lot and plenty of space to roll up the larger unit, to whereas a high-rise in an urban environment would present challenges, and we'd need to consider alleys, loading docks, and possibly street closures. And that's for buildings with lot line to lot line construction. And in either scenario, we would need to look at the fuel supply to these units for an indefinite duration of at least 24 hours. And that could be via natural gas in the area or a diesel line in storage. And Bob or Mike, I didn't know if you had anything to add to those points.
No, I don't, Andrew. I think you're hitting on the key points. Were you going to talk about technology briefly?
Yep, and then finally, you know, just considering the low voltage systems ensuring that there's adequate Wi-Fi, phone and data connections. The television monitors can be used and converted for electronic means and data signaling for the not only the end user and occupants, but the what we'll call the hospital staff as well. Typically in a hotel setting, the Wi-Fi is designed such that its signal strength is suitable for full capacity. Therefore, the likelihood is the conversion would experience little to no issues. And then phones are prevalent at the bedside tables as well. And that is all I had for the power distribution.
Yeah, I'll jump in on that. This is Stan in our conversion study. Again, depending on the time frame that is available and how much money there is to spend, we viewed the telephone in the room as the replacement for the nurse call system. It already goes to a central monitored place and can be used that way. I'll talk a little bit about some of the challenges with a hotel as an alternative care facility, and I see some notes in the chat room that lead up to this as well. One of the biggest issues that we're still having, is accurate forecasting that is needed to determine what the actual bed need is. Completely missing as a country, as most states, most municipalities, et cetera. And that's why we had so many of these projects that really began, and some of them will not get finished. Some of them have been converted and are not yet occupied. But a hotel can't easily become a hospital, but it can become something close to a hospital. One of the challenges associated with that is, I see in some of the comments in the chat room about regulations for use of a power strip in a patient room. Absolutely true. We've all experienced that. Unfortunately, those kinds of codes and standards are really coordinated statewide for the most part in the United States. Some states and their respective Department of Health and hospitals, whatever it's called in their particular state, were good about acting quickly to identify what can and cannot be relaxed in an alternative care setting. Other states did not act so quickly. Get some guidance from CMS, but that's, again, from CMS and not that particular state. So that sort of code-compliant information was hard to come by. I will let you know, in case you don't already, that there's already some conversation with FGI about either creating an additional chapter associated with this sort of event, or at least a set of guidelines associated with that. And I believe that work's going to begin very quickly, and I think they hope to get it out by the end of the summer, if I remember that correctly. Challenge, deciding the acuity of the patient. Number one, as I've already mentioned, and then the single biggest challenge really is who is paying for it determines how fast the conversion can happen. Well, heard a lot about the Corps of Engineers coordinating this work, and they did do that, but very frequently it was actually coordinated by the Emergency Preparedness Office for either the state or the county or municipality for that area, and they worked with the Corps of Engineers. Of course, the Corps of Engineers brings the money, but they weren't actually making the decision about which conversions were going to get funded or not. We were on a call with them a week or so ago, and at that point in time, they had done 820 assessments of facilities for potential conversion and had 17 contracts. So it's a cumbersome process that is made more cumbersome because of what I think really is a lack of coordination across the country in terms of emergency preparedness. Mike, Bob, any other things I missed there?
I'd just like to add one thing to this, and it's really about how we look at building designs in the future, and let's stay specific to hotels in this application, because like Stan said, you can convert, you can use hotels for healthcare, but you really can't convert a hotel to a hospital. But what if you could? And what would it take to design the infrastructure in a hotel that would allow you to quickly convert it into healthcare usage? Obviously, there's cost involved in that. We were throwing around some numbers earlier. It might be a $10 or $15 per square foot increase in the HVAC system, and probably the same for power. But it certainly pales in comparison to what some of these projects have cost the country to convert convention centers for healthcare usage. So it's an intriguing topic, and one that really I think should be explored both from an architecture and an engineering side. We'll certainly be looking into that at IMEG to see what the engineering implications would be.
Yeah, Bob, actually we've talked about that with some of our hotel clients as well, and a model that seems to make sense if we want to plan in advance for this is that the larger cities or municipalities contract in advance with a hotel operator, organization, et cetera, to prepare at least a facility in the community for such a conversion, and then hope it never happens.
Great, thank you all. Go ahead.
So I'm just going to address some of these questions, or if you, Kara, you want to kind of organize that.
Yeah, sure. So we've had a few questions, and keep them coming. I put our presenters' email addresses and my own in the chat box. So if we finish up and you still have more questions, feel free to email any of us. And we'll direct it to the right person. One question came in: why not use hotels for low acuity and convert mainly hospital beds, top levels, to isolation rooms to be ventilated up to the roof? Less cross-contamination. Isolation is mainly HVAC. Thoughts on that?
Yeah, this is Mike, and I think that's kind of the whole parameter of this thought with this alternate care site. These are for the low acuity type patients, and that would then allow the sickest of the sick to stay within the main hospital, where all of these services, all this infrastructure that is required for that type of high-level acuity patient would be available. From the airborne infection isolation room, from the medical cast, from the life safety items associated with it, that would probably be the intent. We did look at and said, what would it take to convert a hotel room, a hotel floor, to negative pressure or isolation? And that really comes down to the cost and the speed of construction. Stan alluded to this. Who's going to pay for this, and what is that process? And it can get really expensive really fast if you look at converting the hotel rooms to airborne infection isolation rooms.
Great, thank you. Are there any concerns with carpet protection tape ripping or needing to be replaced?
Sure. That's an Apollo 13 style idea right there. Carpet protection tape is readily available. I think they're generally in 24-inch wide and 200 feet long rolls at less than $50, and the way that we calculated it, one roll will cover one room, essentially, just kind of as a frame of reference. So absolutely, they could be torn. We might start with 2 layers of that tape to protect against that. Imagine, though, that it's not going to have the same kind of traffic as a typical hospital room. There's no visitation, just staff. And so, yeah, it's an issue. But in a pinch, when speed and resources are primary, it could serve as a barrier for between the patient and the carpet.
Great, thanks, Dan. Have either of your teams or your joint teams actually worked through this type of a conversion yet?
From IMEG's standpoint, we have.
Yeah, go ahead.
Oh, sorry, Stan.
No,
I'll go first.
No, go
from
ahead.
From IMEG's standpoint, we have gotten to the level of planning, and then as Stan alluded to, have seen the numbers and the needs for these dissipate as this crisis has continued. So actual installations from a hotel to a alternate care site, we don't have any that have gone through the full implementation.
Yeah, we're involved in 2 conversion processes right now, one in Michigan, at Novi, Michigan, in a convention center. Started out, the contract was for 1,100 beds. I think it's down to 250 at this point in time. And in Hagerstown, Maryland, we're in the process of converting formerly a correctional facility into a hospital. We have been, as Mike alluded to, we have been engaged or almost engaged in a number of other conversions that either lost traction, went to another architecture firm, another provider, et cetera. I am aware that the Sheraton Hotel in New Orleans is or has been converted into a patient care facility. So at least, and there have been a number of hotels that have provided rooms or given some preferred contracting to healthcare organizations so that their staff can sleep there. But that's not the same thing as converting it to a low acuity care center.
Great. Could a typical hotel, not a high-end in a city, but a typical plain hotel be converted? There are a lot of more of those choices around the U.S. rather than the high-end hotels. Do you have thoughts on that?
Yeah, I think the approach is the same. If you're referring to the Hampton Inns or the other 3-4 story type buildings, no reason why they couldn't. Those are the types of properties that typically have the V-tax or the P-tax, so the outside air consideration is important there, and it might impose some restrictions or limitations just for air exchanges that you'd want to achieve just for a healthier indoor environment. But yeah, no reason why not.
Well, from an architectural perspective, they do generally not have some of the other elements that a full-service hotel would have, like a kitchen, larger spaces that can be used for a nurse station, for command center, for triage, and again, if we need to create a step-up ward for patients if their acuity increases before they can get transferred back to a hospital. So I think it's absolutely possible. It's not, from an architectural perspective, it's not ideal because of some of those other constraints. But I'll point to the future. And next Friday, a high school can be used for this same sort of alternative care facility, and it does have a kitchen, and it probably does have a laundry because of the sports, and it's got some of those open spaces. So a little teaser for what we might experience next week.
Great, thank you. This is an interesting question. There are a number of studies and articles discussing the risks of waterborne pathogens developing in vacant hotels from epidemiologists and water management professionals. What are your thoughts on what to do to make sure the secondary infections don't occur from the drinking water?
This is a concern not just in hotels, but any vacant building right now during this massive quarantine. Schools, office buildings, it is a major concern, and some facilities are addressing it by having people on staff to make sure that there is not all of this stagnant water and the water treatment is ongoing. We know that's not occurring. So one of the recommendations we're making is when they open up the economy and open up these type of facilities, you've got to do some type of water test. And if worst case, you may need to flush your entire domestic water system in order to get some of those pathogens out. It really is about preparing for it and putting in the measures in place and being aware of it, but we know that that is a major concern.
Great, thank you. Is the upfront capability to convert the hotel to a hospital something that should be pursued with FEMA as emergency preparedness?
The studies that... Oh, go ahead.
Go ahead, Bob. No, you go ahead.
Oh, okay, this is Mike from IMEG. Yeah, our studies with this have came through the Army Corps of Engineers, and there are some FEMA contracts as well that are kind of driving that portion, but that is probably one of the entities and tools that is going to drive these to be a possibility as it's currently set up.
Great. This question has come a couple of times about the corridor width of hotels and them being less than hospitals to allow for turning radius required for hospitals and gurneys. Stan, do you have any thoughts on that?
Yeah, it depends on the hotel, but generally speaking, I think that we're not going to find 8-foot wide corridors everywhere. And that's one of those issues, one of those compromises that we would have to make if, I kind of see this hotel becoming a semi-hospital as a worst-case scenario, and that's one of the concessions or compromises that we would have to make in that regard. The good news is, as with low acuity patients, we're generally not going to have the same kind of stretcher traffic that we would have in a traditional hospital. And we're not wheeling around hospital beds in the size that they are. And if we just use a stretcher very similar to what they might use for an ambulance or emergency management service, we can get the patient from one place to another.
Okay. And what about room finishes? Do you need to consider the consideration of sterilization to avoid the risk of infection? And also the question came in kind of related to that on whether you use the existing hospital bed or if you remove it and put in a new bed.
In our study, we left the hotel bed there. It's there. It's not hospital height. It's not like a hospital bed. But again, if time and resources are critical, those beds already exist. The room finishes are an issue, and we actually have a schedule that I neglected to put in this slide deck. And so, Kara, if I can get it to you before you send this out or make this available on the website, we can include that, and it covers some of these things. But we would certainly want to remove the curtains, as many of the soft surface finished things as possible that are in the room before we start caring for patients there. Now, in the conversations that we've had with actual hotel operators, their number one question has been, what are we going to do on the back end after this is all over to make sure that our hotel properties aren't stigmatized by this and guests are willing to come back and stay at the hotel? That certainly involves the decontamination processes that actually CMS has created for some of these kinds of things. But it also is a psychological thing. And so what we are imagining for these conversions, if they actually happen, is that the soft interior finishes would probably all have to be replaced. Wallpaper, carpet, soft furniture,
Right.
etc.
Stan, just as an industry in general, once hotels open back up, they're going to have, I think, a real challenge convincing guests that their rooms are clean, and I'm not really sure what the plan is to do that. Do you indicate that you've fumigated the room after each use? spreads aren't typically washed between guests. That's probably going to have to change. But the industry as a whole is going to encounter a new paradigm, basically, in how they clean their rooms.
I think that's right, and I think that there's also an industry that's going to pop up after that. After this, we've been asked by a number of operators, so where can I go to get a certification that my hotel is safe from COVID-19?
Yeah.
Can FEMA certify that or can CMS certify? And the answer to that is that CMS is not going to do that, and FEMA is not going to do that. But I can promise you that with the free market and enterprise in America, somebody is going to be doing that. Whether it's valid or not is another issue, but somebody's going to be offering that service. And so we're actually have our interiors folks trying to work with some hotel operators to identify what they can do, what kind of set of guidelines can they do that they can communicate or advertise to the guests that this is what we've done, this is what it follows, this is why it's safe. And to me, I think that is really one of the number one things going on right now is how to cross that psychological barrier.
All right. So we're looking for new opportunities following this pandemic. That certainly could be a new business for somebody.
Oh yeah, we've been in discussions about hydrogen peroxide fogging the rooms and all sorts of stuff that in hospitals you're familiar with. The hotel industry is not so much familiar with those things right now.
Yep.
And again, I see Peter's question here, why do we need a guarantee? Peter, it's a psychological issue.
Yeah, and related to that is the idea of plumbing fixtures. We've got a question from Christopher Lohr. Are there recommendations in swapping out the plumbing fixtures of the non-healthcare buildings to prevent waterborne pathogen outbreaks?
Oh, Mike, do you
Sorry,
have
I was on mute there. Yeah. No, sorry about that. No, the thought process right now, again, back to cost, time, and speed, is to keep the plumbing fixtures that are currently there within the hotel environment at this point. Bob can talk a little bit about the heating system, the redundancy of the domestic water with typical hotel applications.
Yeah, certainly hotels are designed to make sure you don't run out of hot water. It's delivered to the guest room at 120, to kitchens at higher temperatures, public spaces at 110. All of those temperatures can be changed to match requirements of a healthcare setting. So those are robust systems in hotels.
Great. I see a question regarding this recording of the presentation. We will be posting this on the ASHE website on our COVID resources page, and we have a specific section for alternate care sites, and this recording and webinar will go up on that. Back to a few more questions, and then we'll probably have to log off because we're way past our time, actually. The question has come in about room heights in hotels and the ceiling fixtures. Is that going to be an issue?
We don't think so. Again, it's a low acuity operation, and that generally would not be an issue. In a ward setting, whether it's in a ballroom or a conference room or a event space room, those ceiling heights are very high. They're actually designed so that they can support things hanging from them. And we have done studies on higher acuity uses in that area where we're actually hanging the distribution of the medical gas from the ceilings as opposed to trying to snake that through the space on the floor, under the floor.
Great. A question came in earlier about nurses' stations and where those are going to be located.
Yeah, we would generally, in the plan, again, depending on the layout of the exact hotel, but we would generally convert one of the rooms in an area to a nurse's station so that they would be relatively centrally located.
Does the same go for the FF&E being stored?
Again, that's one of the beauties of the large full-service convention hotel is the FF&E that is removed from the room can be stored in one of those larger spaces or in an administrative area if we needed to use all the guest rooms for patient care or staff lodging.
Great. I think we had another question earlier about UPS for the system.
Yeah, I saw that. This is Andrew again, and I think it's an excellent point that wasn't touched on. Certainly consideration will need to be given to bridge the gap, as we say, during the power outage for systems that are deemed more critical, whether that's the patient monitors, the nurses' station equipment, or anything providing power to medical gas alarms and things of that nature. So in typical hotel construction, you actually have IDF closets, not necessarily on every floor, and the redundancy in those closets is rack-mounted, something no more than, anywhere from 3 to 8 minutes, which would be fine but may not have the power capacity output to cover some of the loads on a per-floor basis. So, we would want to accommodate likely anywhere short of about a kW per room to make sure there's sustainable power, and that's something that would probably be done as a small, more centrally located or centrally powered UPS on each floor, more likely than it would be an existing rack mount that would support like a hotel network. Things such as the HEPA filter likely are able to withstand that gap of power, which is 10 seconds, and come back online, if that answers the question.
Great, thank you. Any special consideration regarding linen or waste management?
Yeah, we would deal with waste management as just one of the 7 flows of healthcare. One of the first things that we would do in planning for this conversion is map out those flows. Typically, a large hotel is capable of dealing with a lot of waste, and we would take advantage of those systems, their dock, all their facilities that they have there. And again, we would try to keep those flows unidirectional to the greatest extent possible. And some of the larger hotels, we'd be able to have patient elevators, staff elevators, may be able to separate clean and dirty elevators just based on what the resources are that are there. So we think that'd be okay, and we would use the hotel linen initially. Most of these large hotels have laundry services. We'd take advantage of that.
Great. What about pharmaceuticals? Have you considered where those where the med prep would take place and where they might be stored?
Again, we depending on the size of the conversion, how many patients were going to be used there, we would probably create a central pharmacy on the first floor, and maybe in the event space somewhere, but we'd definitely need a pharmacy there. Would have to have just physical runners to get from there to the guest room floors, just because there's no pneumatic tube system or any of the kinds of things that we're used to. And we'd also have a satellite lab there. We would imagine that when we originally did this planning, would be processing some of these COVID-19 tests and other just general tests that happen along the way. Might as well mention this while I'm still talking, is that This is not really generally an issue for ASHE members, but we're around it all the time. Initially, we are recommending that in a quick conversion, the electronic medical record process would be done manually. Imagine if, half the staff that is moved into this emergency situation uses Epic, and a third of the folks use Meditech, and the rest of them use Cerner. How are they going to play together? And we don't have time to create that infrastructure. We don't have time to do that training. So we're back, at least initially, to paper records.
Great, thank you. And we're really out of time here, but I'm going to have one more question, and then we'll go ahead and sign off. Before I do this final question, for everybody on the call, next Friday we are going to have another session with the same panelists. There might be one different, or with at least Stan and Mike on it's going to be a town hall style session on converting spaces to alternate care sites. And we also will be posting a webinar on school conversions, so you can all get an idea on that process as well. So one final question, if we don't have the availability to get negative air machines and the hotel room has P-TECH unit, any idea how to create negative air?
Mm-hmm.
Mike, why don't you go ahead? You've looked into these retrofits.
Yeah. So that's one of the comments. I know there's been as a lot of even inpatient hospitals have looked at how do they convert their med-surg patient rooms to airborne infection isolation rooms. One of the solutions is to use these portable HEPA filters or portable air scrubbers. So I know there, as an industry, has been a shortage in availability to do that. One of the items that we have looked at if we were in this hotel setting is really to build what we would call a sally port or a vestibule on a hotel wing, and that would be our differentiating pressure location from the COVID-19 potential patients from the other locations. When we think about negative pressure, it's really a containment measure. And by placing that type of sally port or vestibule within there, that would then allow us to maybe only use a single HEPA filter or HEPA air scrubber to do that, and that would create that containment measure to separate those two locations.
Great, thank you. With that, I know I shared emails in the chat box. Feel free to email any of us on the panel. And if you missed those, you can always find me on the ASHE website under staff, and I will relay the messages on to the team. I'll go ahead and turn it over to Benjamin now.
Thank you, Kara. Thank you, everyone, and all the participants and speakers today for their time. Like Kara said, we will be posting this to the ASHE COVID-19 resource page, so be on the lookout for that. If you have any questions, please feel free to email Kara or the speakers today, and thank you for your time. David, you're turning over to you.
Well, ladies and gentlemen, that concludes today's presentation. You may disconnect your phone lines, log off your webinars, and thank you for joining us today.